Now it's my absolute pleasure to introduce Dr. Moji Akinsola, who's going to talk to us about pre-pregnancy care and gestational diabetes. Thank you, Dr. Akinsola.
Thank you very much, Joan, and it's lovely to be here presenting to you this evening. So I'm going to spend some time talking about pre-pregnancy care and gestational diabetes. I won't spend a lot of time talking about type 1 and type 2 because time will not permit. The first important point I want to get across is that diabetes in pregnancy is actually extremely common. And in fact, if we consider that 700,000 women give birth in England and Wales every year, up to 5% of these women will have a form of diabetes. By far the most common form of diabetes is gestational diabetes, which can affect 1 in every 23 pregnancies. So diabetes in pregnancy is actually the most common medical condition that you're likely to come across during pregnancy. The National Pregnancy and Diabetes Audit was first published in 2014, and what this audit did was look at all diabetic pregnancies in England and Wales, and then gave a very important report, which was first published in 2014. It was supposed to be an annual audit, but unfortunately, due to the pandemic, the last one was actually in 2018, published in 2019. And one of the important findings from the audit was that most patients with diabetes who were pregnant actually had type 2 diabetes, and only 1 in 8 women were adequately prepared for pregnancy.
So, Dr. Akinsola, if I can just ask you about those first two really important points that you've raised for us, that you said diabetes in pregnancy, and correct me if I'm wrong, that's what we're calling gestational diabetes. Is that correct?
So thank you, Joan. When I talk about diabetes in pregnancy, it's actually all forms of diabetes.
Okay.
So that includes women with pre-existing type 1 and type 2. But by far the commonest cause of diabetes in pregnancy is in those women that develop diabetes when they're actually pregnant. And that is what makes up the huge number of patients that have diabetes who are pregnant.
So I think a lot of us as healthcare professionals, particularly in primary care, would probably think that something like hypertension in pregnancy is actually more common. So it's really fascinating to hear that statistic, that when you put all forms of diabetes in pregnancy together, it's actually the most common condition that you're going to encounter in secondary care in women who are pregnant. So it's really fascinating to hear that. And presumably you'll bring out some points from the diabetes pregnancy audit, which will help to inform us about the outcome for these women and the outcome for the babies as well.
Yes, absolutely.
Okay, fantastic.
Moving on from there, one of the things that the audit showed was that, in fact, poor control of diabetes prior to pregnancy is actually the most significant risk factor for adverse pregnancy outcomes. And what are those outcomes? We're talking about miscarriage, we're talking about stillbirth, we're talking about heart or birth defects. All of these outcomes are much more common when the HbA1c prior to becoming pregnant is high. And we're going to talk about what constitutes a high pre-pregnancy HbA1c.
And just to clarify for those who may not be fully aware, HbA1c is that average reading of blood glucose over the previous 2 to 3 months, and gives us an indication of how well the diabetes blood glucose levels are going.
Absolutely. So what does it actually mean when we talk about preparing for pregnancy? Even if you consider women that don't have diabetes, preparing for pregnancy is actually something that's quite difficult to do. But for women with diabetes, it's absolutely crucial, because we know from the National Pregnancy and Diabetes Audit that if women can prepare adequately for pregnancy, then there's going to be much better outcomes, not just for the mother, but for the baby. So the first thing is actually, as healthcare professionals, is that any opportunity that we have when we see a woman with diabetes, we should be asking the question, are you thinking about pregnancy? And if they aren't, then they should be on some form of adequate contraception. And it's really important to highlight at this point that all forms of contraception can be used in women who have diabetes, but you do have to think about individual risk factors in making your choice. I know women sometimes worry that because they have diabetes, this may affect their fertility. In actual fact, diabetes per se doesn't affect fertility. However, poor diabetes control can increase the risk of having a miscarriage. So obviously, with that in mind, that's another reason to highlight and emphasize to women the need to improve diabetes control prior to even becoming pregnant.
So, Dr. Akinsola, getting fit for pregnancy, you've said is really, really important. You said that you should aim for an HbA1c that's well controlled, and you're going to give us some more information about what that actually looks like and what that means as in the talk this evening. But you're also saying that prior to pregnancy, whilst you're getting fit, make sure that you have effective contraception, and the contraception, all methods are available and up for discussion with your healthcare professional. You said also, which I think is a really important point, that it doesn't affect the woman's fertility. Can you just clarify, what about in terms of the men? Does it affect their fertility if they're living with diabetes?
So thank you, Joan. So that's obviously a very important point. So again, the diabetes per se doesn't affect fertility in men. However, as you have heard in previous presentations on this forum, men with diabetes often have erectile dysfunction. And of course, that might be a factor that might affect fertility. The other thing we know is that both for men and women with high BMI, that in itself may be a factor that might affect fertility rather than the diabetes itself. So they're all kind of interlinked, but actually having diabetes per se, I think it's really important to emphasize that just because someone has diabetes, that on its own doesn't affect fertility.
Oh, that's hugely helpful, because I'm sure a lot of people would be under the impression that the diabetes itself might be affecting a fertility, but you're not saying that. You're saying that it actually can affect the pregnancy outcome, the pregnancy outcome for the mother and for the baby. And that's equally important. And there's fantastic ways that you can make yourself fit and ready for a healthy pregnancy when you're living with either type 1 or type 2 diabetes. And you're going to tell us a bit more about that.
Absolutely, thank you. So one of the important things to get on board quite quickly is folic acid. Any woman that's trying to become pregnant should be having folic acid. The normal dose of folic acid for the woman without diabetes is 400 micrograms. And even for women without diabetes, getting them on folic acid is quite a challenge, as I'm sure you know, Joan. But for women with diabetes, it's absolutely crucial that they have folic acid 5 milligrams. This has to be prescribed. It can't be bought over the counter. And it's advised that this is started at least 3 months prior to conception, and that is to reduce the risks of spina bifida or other sort of cardiac malformation. So it's really, really important. It's also very important that the HbA1c, which we alluded to earlier, has to be below 48 millimoles per mole, or in people that deal with old currency, you're talking about 6.5%. Now that is extremely tight control, but we know that HbA1cs of this level are associated with better outcomes for babies in terms of congenital malformation rates. And that is not something to be underestimated. So how do we ensure...
Sorry, it's just about the folic acid, because so often in primary care, somebody would come and see me and they were already pregnant and hadn't started the folic acid. So I just want to, shout again that message. If you are thinking of trying to become pregnant, do start your folic acid. If you're living with type 1 or type 2 diabetes, that's got to be 5 milligrams of folic acid. You can't get it over the counter. It has to be prescribed, so you've got to see your healthcare professional. That's certainly the case in the UK. And if you are not living with those conditions or any other medical conditions, then it's the 400 micrograms which you can get over the counter. So it's all about getting into that mindset of preparing for pregnancy. And I think that can be a bit of a change of mindset for a lot of people, don't you think? That most people would think you don't have to prepare to get pregnant, you just go and try.
Just go and get it done, exactly.
But in these circumstances, you're saying very clearly to optimize your chances for a healthy pregnancy, healthy delivery, healthy baby, prepare. Yeah.
Absolutely,
Yeah.
prepare. And going back to the folic acid, even if by chance you weren't able to take it prior to conception, it's still important that as soon as pregnancy is confirmed, folic acid should still be prescribed, and it should be taken up to 12 weeks. So in other words, till the end of the first trimester. After that, you can go down to the lower dose, which is found in the Pregnacare preparations, and that would just be the 400 micrograms along with other pregnancy vitamins. But the 5 milligrams is absolutely crucial. As much as possible, get it in early. So to help support women, they need to be doing regular capillary blood glucose monitoring, and the aims are for pre-meals less than 5.3, 1 hour post-meal of less than 7.8. For women with type 1 diabetes, some of them are on CGMS or they use the flash glucose monitoring sensor system, then we're looking for them to achieve 70% of the time that their blood glucose levels are in range, and by that we mean between 3.9 to 10. It's really important that if a woman has an HbA1c of greater than 86 millimoles per mole, or in old currency 10%, pregnancy should be avoided if at all possible, because we know that at that level there is a much higher chance of babies having birth defects. Women that have type 1, it's important to make sure they're on the right types of insulin. And for women with type 2, it's really important to highlight at this stage that the only tablet form of medication that is safe in pregnancy is metformin. All other diabetes oral agents are not safe and have to be stopped. And that also is the case for GLP-1s such as Victoza and Trulicity, etc. So for women with type 2 on metformin, if the diabetes is not adequately controlled, they need to start insulin. And so that conversation has to be had sooner rather than later. Just to note that the other tablets that are commonly used for women with diabetes, blood pressure tablets, cholesterol lowering tablets, they all have to be stopped. They're not safe in pregnancy. If a woman does have high blood pressure, there are other safer blood pressure lowering medications that they can be switched onto.
So there's really lots of reasons to be thinking about preparation. And also you mentioned about the medication. I think it's, again, really important, both from the point of view of the healthcare professional and the person who is trying to become pregnant or who becomes pregnant, that the medication is reviewed and those medications that aren't appropriate to continue during pregnancy are stopped. But I've found quite often that people will come once they are pregnant as opposed to, before that actually happens. And then it's about stopping it as soon as possible. Has that been your experience?
Absolutely, Joan. And in fact, you highlighted a really key point. So the National Pregnancy and Diabetes Audit highlighted that for women with type 2, who are by far the commonest type of pre-existing diabetes in pregnancy, up to 50% of those women are not seen in antenatal care in the first 10 weeks of pregnancy. So what that means is quite a large number of patients are going to be on those medications that ideally are supposed to have been discontinued.
I suppose we've all got the responsibility. So as healthcare professionals, we've got the responsibility, as you said earlier, to have those conversations with women who might be considering having a pregnancy, and that's really all women within a certain age range, perhaps, but having those conversations repeatedly, because we wouldn't necessarily know when that person makes that decision unless they come and see us about it. And then for the person who is living with type 1 or type 2 diabetes, again, the responsibility we hope arising from this is, with the increased knowledge and awareness, that you will consult with your healthcare professional when you're even considering becoming pregnant, so that we can help you to optimize a healthy pregnancy. Yeah.